very warm welcome to you all to the seminar on long COVID. My name is Parveen Kumar and I have the pleasure of chairing the Board of Science for the BMA. I'm an Emerita Professor of Medicine and Education at Barts in the London Medical School, Queen Mary University of London. So this is the last of our 3 virtual seminars that the Board of Science has hosted this year. The others have been on knife crime, climate change, and today on long COVID. Before I explain the programme, just 1 or 2 housekeeping rules. Firstly, you'll be able to submit questions. Obviously, this is live. There's a Q&A box on your right-hand side. And if you'd like to ask someone, or if you've seen someone else ask a question you'd like, please put a thumbs up sign, as it's popular questions will be more likely to be asked. We will also, of course, be asking the many questions that attendees have pre-submitted on registration. So the programme, just to put you into sync with what's going to happen, we've divided it into 3 parts, essentially, with speakers, all of whom are expert in the field. Firstly, we'll discuss what long COVID actually means. We'll also have a patient who suffers from it, describing what it's been like to live with long COVID. We'll then have a series of 3 short lectures on research into the various aspects of COVID, and we'll then end with a talk on rehabilitation. This will be followed by a panel discussion, answering all the questions that we've had or we've received, and this will be led by Dr. David Strain, who's on the board and an expert on COVID. In this seminar, we hope to discuss the many unknowns about coronavirus and its infection. Currently, there's no universally agreed definition for long COVID, but a significant number of people who had the viral infection have reported persistent symptoms. Recently, it's been estimated that about 1 million, yes, 1 million people in the UK were experiencing symptoms, and some many months after the acute episode. There also appears to be no direct correlation between both the severity of the acute episode and the persistence of symptoms. The data suggests that the long-term concern for health of the population should be looked at alongside the number of hospital admissions and the mortality figures, because I think 1 million is a huge number of people. But also there's going to be substantial neurological and psychiatric morbidity impact from the long COVID problems. But we'll just be discussing all these and other problems. So firstly, I'd like to introduce Dr. David Strain. David has been one of the leads on COVID for the BMA and is also co-hosting this seminar with me. David is a senior lecturer at the University of Exeter Medical School. He'll be talking about what is long COVID and also introducing the lived experience with a patient, Dr. Amy Small, who will be talking to us. So David, over to you.
Thank you very much, Parveen, and it is such a pleasure to be here. So I've been given the task with introducing some of the finest speakers and the finest researchers in long COVID and talking about what actually this condition is. It was first identified in May 2020 by Eleanor Peregro. She was a researcher. She's an archaeologist based at UCL, although she is Italian origin, and actually caught COVID in the first wave in Lombardy. And she's a person who put this term, long COVID, onto Twitter back in May. Now, this is a long time before we'd even appreciated that the disease was causing these long-term consequences. However, a month before that, at an RCGP symposium on this subject, it was already stated that it would be incredibly unusual if COVID didn't cause long-term consequences. Indeed, that has been a manifestation of many other diseases that have gone before. The biggest case of this would, of course, be the pandemic of 1918, the Spanish influenza that ripped around the country and left many people in a condition of, well, it was absolutely perfectly described in the Oliver Stone's book, The Awakenings. Many of you will have seen the film with Robert De Niro and Robin Williams that highlighted the discovery of levodopa and the escalation of those doses of levodopa to treat Parkinsonism. What is often missed, though, is all of those patients in that particular book and the film were left with the long-term consequences of the flu. Now, that was one manifestation. Since then, there have been many, many other post-viral manifestations, and therefore it was no surprise at all that long COVID came about. We knew from the outset that the coronavirus was attacking the mitochondria. It was using the ACE2 enzyme to enter the cells. And remember, the ACE2 enzyme is responsible for breaking down the angiotensin into angiotensin 1 to 7 and angiotensin 1 to 9, which in turn activate the mitochondrial assembly receptor and are responsible for many of the antioxidant and anti-inflammatory roles within the cells. We saw that in the acute illness. But also the post-viral illness has left many debilitated. As Parveen says, there are approximately 1 million people in the UK at the moment who describe themselves as having symptoms beyond 4 weeks. And that's what our nice definition is for prolonged COVID, for a post-acute infection. Beyond 4 weeks, it's 1 million. If you look at those beyond 12 weeks, which is when we start considering this as a longer term condition, we're left with about 900,000. If you look at 12 months, there are currently 376,000 people in the UK with symptoms beyond that, because that's starting to take in the first wave. Clearly, that number will grow as we get to 12 months after the second wave. We also are seeing around 200,000 people who are incapable of work because of their symptoms. And the symptoms are described in many different arenas. We see the post-ITU syndrome. We see people who've got the respiratory scarring or cardiac myocarditis, which are all very much in keeping with the severity of their original disease. But there's a much larger number of patients who had relatively minor initial infections. And I say minor infections, we don't want to call any infection that's leaving people with complications 12 months later as minor, but that acute presentation, that immediate experience of COVID was that it was little more than a significant flu-like illness. And yet they've been left with a catalogue of symptoms. They've been left with fatigue. That's what's being termed brain fog, the difficulty in focusing, the difficulty in concentrating. They've been left with myalgia, pain expressing throughout all of their muscles. And the symptoms do seem to track. The greater the symptoms in one arena, the greater the symptoms in multiple arenas. Now, the UK has been one of the first to recognise this. Matt Hancock was the first to put money behind an assessment service, and at the time he put this, he had no idea of the scale of the problem. Therefore, the 10 million that he put forward seemed very generous until we realised that we have 1 million people with the condition. He bolstered that with another 25 million to do the assessment service, which actually translates to about £35 per person who has this condition. But on the side of this, we've also been the most rapid to invest in the research. 20 million has already been allocated to the research of the underlying cause of this. There's another 20 million that we're due to hear announcements within the next week or so, looking at potential treatments for this. We have we have external investments. I myself am doing work in the genetics of long COVID, which is due to start tomorrow, and I will be posting the adverts for this. However, actually, with all of this, it seems not much sense for me. It seems not much sense for me to be talking about the symptoms of long COVID when there are people who actually are experiencing this long COVID with us. Now, of those numbers we mentioned, healthcare workers have been disproportionately affected. We've had 122,000 people, whether that be doctors, nurses, therapists, who are all working with acute COVID infection, who have now been left with long COVID. And at this moment, I want to introduce Dr. Amy Small. She's a general practitioner from in Scotland, who is one of our first to experience these long COVID. Welcome, Amy. So would you like to describe to people how you have experienced this condition. You're on mute, Amy. It had to happen at some point.
It had to happen, sorry. It goes back to April last year, when I first got ill. I think, like many others, I stayed at home. I did what I was told. I was had a typical sort of started with a headache, fever, then got quite breathless. And over the course of a couple of weeks, my temperature started to go up rather than down. It was an illness that I've never had anything like that before. I've had the flu a few times, but this felt really quite different. And the breathlessness and watching my oxygen sats drop on a probe every day was quite frightening. But I had a couple of assessments, and I was reassured that I had no DVT or VT at the time, and I thought, well, it'll just get better. The WHO said I'd get better in 10 days, so it'll go away, but it didn't. After 3 weeks, I was still really breathless and febrile, and after a month I was still febrile, but at that stage I was kind of getting quite down because I hadn't left the house except for medical appointments in a month, and wondered if I was still contagious, given that I still had fever. So it was at that point that I contacted infectious diseases and said, oh, can I leave the house? Am I gonna infect everyone? And they said, no, you're not, but we need to see you because this is strange that you've still got fever a month down the line. Of course, we know now that many others with long COVID, like myself, have prolonged pyrexia. And for me, that temperature went on for 7 months. I had daily fevers to above 38, 38.5, even up to 39 sometimes, and that just didn't go away. And it was around that time on social media that you saw these things were coming out, and I realised that I very much wasn't on my own, and wasn't on my own at all because my husband also had long COVID. And so the two of us were trying to muddle through, looking after our 2 little boys who were 3 and 5 at the time, whilst managing our own illnesses. So I just continued to feel incredibly fatigued. It's a fatigue I've never, fatigue's the wrong word. It's like every last ounce of energy is drained away from you. And I learned the hard way after trying to go back to work in June. I was feeling terribly guilty that I hadn't been at work. I wanted to get back. I thought maybe if I got back to work, then I'd start to feel better. So I went and did a half day at work with some paperwork, and that was all right. And the next day I went and did a normal surgery. And that was a huge mistake. It left me bedbound for 10 days. I was so fatigued, I couldn't even drink, I couldn't speak, my jaw muscles were so tired, and all of that had been triggered by a cognitive strain, and that probably set me back about 2 months in my recovery. So over the summer I learned about pacing. I learned what that meant. I got a book that someone recommended to me on Twitter, and I started to appreciate what pacing meant rather than just doing stuff slowly. I saw a nutritionist who helped me cut out sugar and alcohol and caffeine, and gave me all sorts of supplements to try and help me to feel better. I was in a privileged position to be able to do that. But as time went on, I saw infectious diseases again who were worried that I had ongoing fever, and they organised various tests, including CTs and echoes. And the only thing that came back abnormal for me on any of my investigations was a 24-hour ECG, which showed that I was persistently tachycardic, and particularly on any form of exertion. And I had noticed that. I couldn't keep up with my 4-year-old. I couldn't walk alongside him because I was just simply too breathless. And if I did keep up with him, I would pay the price, and the next day I would be in bed. And if I overexerted myself massively, one day I went for an open water swim and thought I will just try and see what that does. And my speech started to slur, my legs didn't work properly, I couldn't think straight, I had severe brain fog, and that again put me in bed for another 3 days afterwards. So I had to learn as I went along as to what I could cope with and what my body couldn't cope with. But really, in terms of me getting better, was a bit of a a funny one, for want of a better word. It was when I had a 6-month cut-off clause in my partnership agreement that said that if I couldn't fulfil my partnership duties over a 6-month period, I would be expelled from the practice. And I was having a meeting with my partners where I figured I was probably going to lose my job at that point because I'd been off sick for too long. And I had some out-of-date propranolol that I'd had from when my father was dying. And I thought, well, I'll just try that and see if that helps get rid of some of my anxiety right now. And not only did it make me feel better, it made me feel so much better. And it was really at that point that I thought, I wonder if I've developed dysautonomia, if I've got POTS. I'd seen a lot of people with long COVID who'd got this diagnosis, and I noticed that whenever I stood up, my heart rate went up to over 100. When I walked up the stairs, it was 140, and minimal exertion just pushed me over the edge. So I phoned my GP and I said, you know, I think I've got POTS, and can I try a beta blocker? So she put me on bisoprolol. And within 2 weeks of losing my job, I was then able to start locuming again. And I think that's one of the messages I've been so keen to get across, that I think it is so important that patients with this illness get timely assessments, timely diagnoses, timely treatments, because actually it can make a huge difference for people. You know, the majority of people with this illness are young. They have jobs, they have caring responsibilities. They're the sandwich generation, as we call them. And, you know, actually, if we can get people feeling better quickly, we can get them back. And the longer that we deteriorate, the longer we decondition, the harder it is to do all that. So, yeah, that's kind of been my journey. I'm now working full time. I do still have relapses. I'm currently coming off the back of one. Lots of birthdays in my family all at the same time have been really trying, and I'm just learning now that I still need to pace and I still need to listen to my body, and I can't burn the candle at both ends as many of us type A medics always have done. So yeah, that's kind of where I'm at now.
So that's a great introduction and a really good description of how patients are feeling. And actually, Amy is amongst the 13.7% of people who are not hospitalized with COVID, who end up with this weird collection of symptoms. POTS, as she describes, is very frequent, that postural orthostatic tachycardic syndrome, relatively easy treated, providing we know it's there. And that's associated with the shortness of breath, it's associated with insomnia, it's associated with many of the other autonomic dysregulation. And we see brain fog, and I think Amy described perfectly that exhaustion comes about not just from physical exhaustion, but also the mental exhaustion, returning to work. And that's something that's actually brought out from previous experience with treating chronic fatigue syndrome and myalgic encephalomyelitis, ME, who also described this phenomenon that it's not just physical activity that highlights the problems. We also hear that the pacing story, and we're going to hear much more about that coming up from Professor Sally Singh, who actually has written many of the guidelines, in fact, basically wrote the book on this, talking about pacing. But can I come back to you from a personal experience, Amy? What does pacing actually mean to you?
Yeah, initially, I just thought he meant slow down and just do stuff more slowly. And I realised that actually, you know, a simple thing like cooking a meal, for example, I would go to the kitchen and I would sit at the table rather than stand at the island, if you like. I would peel the carrots and then I would go back and rest. Then I'd go back an hour later and I would cut the carrots, and then I would go back and rest. And then I would go back later on and cook the carrots. And, you know, for someone who's used to whipping up a stir fry in 10 minutes, this was an incredibly different way of doing things. But it taught me that I had to plan my day. If I knew that I was doing something later on, like picking my kid up from school, I probably couldn't take him to school. If I had to prioritize things. So if I knew that I absolutely had to go to a doctor's appointment, well, then I couldn't take my child to school and someone else would have to do it. So in those early days, it was really looking through my day at the beginning of the day and thinking, what do I have to do? What do I really have to do? And what do I want to do? And it was also that fourth P. We talk about pacing, prioritizing, planning, and then pleasure. So it was also trying to make sure that within my day, I built in stuff that kind of kept me going. But it is about breaking up those tasks and planning it. And that was the other thing I learned, was to have a symptom and activity diary where I could look back at my day, see how I felt, record my symptoms, how much activity had I done, and look back over the week and decide, actually, you've overdone it there. That's too much, and that's why you feel worse now. Or actually, when I'd been at a plateau for a certain amount of time and was functioning well, I thought, well, now I can just try and take it up a level. I can now just try and add a wee bit more into my day. But I learned very quickly that a wee bit more was 10% and not 80%, which is what I normally do. And I was trying to avoid that boom bust thing that I had done so much earlier on in the illness.
So this pacing description that you give is absolutely spot on, and for translating that to our patients, one of the things I spend a lot of time talking about, the analogy I always use is the old iPhone battery, the thing that will just die. And many of you will have experienced that if you have an iPhone and the battery dies in 20 minutes when it's beyond 2 years shelf life, you will realize that if you recharge the battery when it's at 20%, it will go back to normal very, very quickly. If you wait until the battery is exhausted, it takes forever for that phone to recharge and reboot. And Amy's just described that absolutely perfect with the whole carrots. Let's not do the whole thing in one go. We need to make sure that we are getting to a stage where you can know that you've got enough reserve to go and recharge and then come back in a moment. And then the other thing you mentioned there was nutrition. Now, for many of the patients coming to see me, the first thing they do when they're feeling fatigued or when they feel like they can't concentrate is reach for the Lucozade or the high calorie, the high sugar, the rapid release energy. And I know you took nutritionist advice. Do you want to talk a little bit about that? Because that's something that's not widely available within our health service at the moment.
Yeah, I mean, I'm in a privileged position where I could afford that. You know, it's not a cheap option when you do it privately, but essentially she guided me. Initially, the first thing she said was give up sugar. You know, and I think as you described, when we're feeling low, we're feeling fatigued, we reach for the sugar to try and give us that boost. And what she explained to me was that when you have those highs, peaks and troughs with sugar, that it will your body will really struggle so much more. And also what she explained to me was that sugar was very inflammatory. So for someone having persistent pyrexia, sugar is an inflammatory ingredient, along with dairy and gluten in some people. So we went through various different diets, just trying to eat a lot more whole foods, generally eating a lot more healthy. And I have to say, it was much easier to do that when I was ill than now when I'm back working. You know, when you have the time to eat that way, it does help. But she also had me on various different supplements, looking at you know, high dose vitamin D, high dose vitamin C, quercetin, glutathione. Lots of these supplements are used by people with ME and chronic fatigue syndrome as well. So just looking at the mitochondria, basically trying to boost the mitochondria and how they function. And then yes, and I've managed to stay off alcohol and caffeine. I mean, alcohol just makes me feel dreadful, and if you ask anyone with long COVID how alcohol makes them feel, they'll tell you the same. That intolerance sadly has completely gone. But yes, all those things have been really helpful, and I'm trying as best I can to continue that.
And that's an important learning point for those of you who are seeing these patients. The number of patients I've seen that are 3 or 4 months into a long COVID scenario that are almost becoming sarcopenic, and that's not necessarily associated with a big change in the body mass index. We've got several patients that I'm seeing whose body mass index is still in the 30s, low or high 30s. That actually, when you start looking, they've become sarcopenic, because all they're doing is putting the energy in without the protein, without the appropriate supplements. That's one of the key things that when we are treating patients that we need to start thinking about. Now, You also highlighted something else, Amy. You highlighted the need for proper investigations for this. Currently, within the UK, there are 88 long COVID assessment services. These have been put forward as part of the NHS 5-step plan that is planning on trying to tackle long COVID. And as you will have seen in the Times over the weekend, the UK is long COVID central. We're not quite sure whether that's because we had so many cases in the first wave that we're able to identify it, whether that's because there is something about the British environment, the British genetics, the British quality of life, and the appetite, the diets that we eat that leads us to it, or whether that's purely because we've got one of the best primary care networks in the world, and people are coming to our primary care networks talking about symptoms that in other places in the world they just don't have the access to go and have a look for those things. Now, Amy, you mentioned about those initial investigations that you had and how they played a vital role in your life. Would you like to talk a little bit more about what the investigations you feel would be appropriate for someone presenting with long COVID?
So I think that's where we need the expertise of the people who understand about this illness, because it is such a varied illness, you know, and there are so many different manifestations. So I think it's definitely not a one size fits all. I certainly think we should be looking out for the obvious things like dysautonomia. So that's, you know, doing lying and standing blood pressures, pulse rates. There are various easy home tests that can be done to do that. 24-hour ECGs can be helpful. I also think that we need to be looking for those who have chest pain. You know, we are seeing cases of myocarditis, pericarditis, but it's really difficult to pick up. And I think that was highlighted very well last week in the the Royal College of GPs had a seminar on long COVID, and UCLH have a long COVID clinic, and they said that they'd done echo scans on 300 of their patients, of which virtually all those echo scans had come back normal. They had then gone on to cardiac MRI, 70 of those patients, of which 50% of those patients had pericarditis or myocarditis. And this is the difficulty, is who do we scan for these things? And we don't know yet. And I think that's where they were saying that a large bulk of the research needs to go in to work out, to determine who needs these further investigations and who doesn't, because there very much is pathology there. And even those people with mild illness early on, some of them are going on to develop PEs down the line, and we simply don't understand why. And we don't understand who these people are that need to be screened. And I think that's the problem, is people are coming up against seeing perhaps doctors who don't understand enough about the sequelae of long COVID and perhaps aren't being listened to enough. And you are very lucky in England with your long COVID clinics, as you know that we don't have long COVID clinics all over the UK. We certainly don't have any in Scotland, and there are no plans to have any because they want to focus on the research first. But I do feel that, you know, we need to look at baseline stuff, and we also need to remember that not all long COVID is long COVID. You know, we need to make sure that the person with prolonged pyrexia doesn't have lymphoma. So again, you know, just making sure that, yes, if it looks like a duck and quacks like a duck, and, you know, it probably is a duck, but have we made sure that they haven't got other pathology that's going on? I think the UCLH clinic also highlighted the number of other diagnoses that had been missed: breast cancers, lymphomas, other severe illnesses that needed to have been picked up. So what we need is people who understand this illness, who understand what it is, and have access to investigations. That can be done by a GP with the appropriate, you know, supporting AHP structures around them investigations. But there's certainly not a one size fits all, and that's why you have to know about the illness in order to do the relevant investigations.
So they're highlighting looking for alternative diagnoses has to be the first step. And for anyone working in primary care who sees somebody who potentially could have this, we've got to remember that for the last 18 months, people have been staying away, not necessarily for the right reasons. Heart failure can present as symptoms of fatigue and brain fog, as can diabetes. And we've seen a reduction of the new diagnosis of new diabetes of about 30% over the last 12 months. Now, they're definitely out there somewhere. So these simple tests are key in the first instance. So too celiac disease, that can also present with very, very similar tests. And as a bare minimum, we should be checking a full blood count, sugar, we should be checking the renal function, we should be checking the antibodies, the TCG antibodies, looking for those conditions, which all can present with the same. But one of the key elements in that is telling our patients from the outset that those tests we are doing to make sure that it isn't anything other than long COVID. Amy did mention one of the other elements of long COVID that many of the population are currently going through. You get a series of normal tests. You get a normal full blood count, you get normal renal function, they have a normal echo, a normal CT scan, normal D-dimers, and all of those other tests, and they're told there's nothing wrong. Long COVID is having some profound psychological impact on some patients. And telling them there's nothing wrong is the worst thing we can do. Currently, we don't have the right investigations for managing these patients. Currently, we don't know what the right treatment is. We don't know what the right way of diagnosing this condition is. And we're going to hear a lot more about that over the next hour. However, if you go back 100 years, the management of diabetes was, well, watch them die. If you go back 50 years, we were just finding out about the demyelination process that leads to multiple sclerosis. But there were hundreds of thousands of patients worldwide that were being told this is all in your head because we didn't have the MRI technology. We didn't know about those demyelinating plaques that were occurring. Therefore, all of the existing tests at that time were being normal. If we go today, we've had patients of the last 20 to 30 years with CFS and ME who have been told incorrectly that there is nothing wrong with them because we don't have the right tests as yet to determine what is wrong with them. And a key element of reassuring people, a key element of supporting people who've gone through these conditions with lots of normal tests is that psychological support. For many, they will be suffering post-traumatic stress disorder. Many are losing their ability to function normally in the things that they identify as themselves. Remember, for many of us, we identify through our parenting and we identify through our jobs, we identify through our social activities. If they are taken away from us by some condition, there's no wonder that we're going to end up with patients presenting with depression. That doesn't mean that's the underlying cause. I mean, I know, Amy, when we were talking to you earlier, you did mention the impact that this had on your ability to look after your 4-year-old. You lost your job. How did that make you feel? What is the things that we could have done better in order to support you and people like you who are going through this?
I think it would have been really helpful to have, I mean, I was lucky in that I had a private psychologist that I was seeing. So, you know, on that front, I had appropriate psychological support from early on in my illness. I think you feel so alone and so frightened for the future. And there I was, I lost my job, my roof was leaking, we were in the middle of remortgaging. My husband was also off sick, so we were about to go from, you know, a 2-salary household to half of his at that point. And it was absolutely terrifying. I think, you know, certainly patient support groups have been really helpful, you know, knowing that you're not in it alone. We had a doctors with long COVID support group that's been incredibly helpful, and that got a lot of solace from that, speaking to others who are going through the same thing. And I know that a lot of patients out there get a lot of support from other groups that they're in as well. And I think it's also just hopefully at some point some reassurance that one will get better. And I know that's not always easy to provide, but I think yes, trying to see that there is a future for us, that we, you know, and that we will get better. And I think it's always helpful hearing recovery stories, but it's very difficult for those who are left behind, and for those who aren't getting better, and for those who don't have the answers. And there is no doubt that after a prolonged period of illness, you know, you're going to feel frustrated, and some will develop depression and anxiety alongside that. And I guess it's just about making sure that the appropriate support is there psychologically for patients, but also I think not conflating the mental illness aspect with the symptoms, because I think a lot of people are worried that when they're presented with a psychologist that they might be told it's all in your head, now get better, you know. And I think that's about how that service is delivered. It's really important to not gaslight, and to support patients in the way that's most appropriate for them.
Yeah, so that's a really important learning point. When anybody presents with this condition, the first thing to do is acknowledge the condition, to accept the fact that this is not in the head. Normal tests do not mean it is normal. And the fact that there is overlying psychological disturbance is very important to accept, important to appreciate, important to recognize, but do not attribute the very physical manifestations on those psychological impact that will have had on people. And so Amy's just touched on the last of the messages that we need to be getting across to people. And actually, that's one of the things that we're hoping today's event is going to start giving hope towards, that there is solutions out there. There are things that are starting to make a difference. We're starting to get a better understanding of what the demographics are. The demographics of long COVID are different to the demographics of acute COVID. We see that we are more likely to see this in women than we are in men. There's a lot of uncertainty about whether that's because women are just better at looking after themselves and therefore attend the doctors more regularly, more frequently with important considerations, whereas men are less likely to end and more likely to ignore based on previous records of multiple different conditions where men report later. It could be difference in the genetics that leads to this. It could be difference in mitochondria function. We do appear that the patients presenting with long COVID tend to be younger than those who are presenting with acute COVID. That is a very important consideration as we start looking at the vaccine program. The vaccine program is successfully rolled out amongst the older population. It's been dramatically reduced the number of acute cases in the elderly and the very frail. It has also done a lot of the work to break the link between catching COVID and hospitalization and ITU. However, vaccines amongst the younger population, vaccines amongst patients who are actually at higher risk of long COVID, still remains hesitant. There still remains uncertainty. And also with people with long COVID, there is a great concern about whether they should be being vaccinated or not. We are seeing patients who've got long COVID feel, well, I've already had the virus. Can I catch it again? There is very clear examples where the answer to that is simply yes. In Manaus in Brazil, 82% of the population's got antibodies to the original B177 virus, the original virus that spread around the globe. They then eased lockdowns. They dispensed with the mask. They started having social gatherings again. 6 weeks after they started their social gatherings, the P1 variant emerged, the variant that we now call the Gamma variant, that then swept through a population who'd been previously infected before. As a result, the importance of vaccination, even in those who've had COVID, has been highlighted and being pressed forward. But for people with long COVID, worried that there might be an autoimmune impact of that, how do you feel about that, Amy? How would you feel about going for vaccinations, and how does it make you feel when you have it?
Well, I was one of the people that didn't feel any different after having it. So, I mean, other than I felt horrendous for 48 hours with a high fever, but it didn't affect my long COVID. What I would say is I have had colleagues with long COVID who have had COVID for a second time and have been hospitalised as a consequence. So we absolutely can catch it again, and there's no doubt with the different strains coming that I don't think having had COVID is a reason enough to not get it. I certainly feel more protected now having it. I feel less anxious. I was working in COVID assessment centres prior to being vaccinated, and I certainly felt a hell of a lot safer doing that after having been vaccinated. My husband didn't feel any different either after he had his vaccination, but I know others who felt much better since having theirs. So, who knows? But I certainly think that we need to promote the vaccination. We need to try and aim for us all being protected, because we absolutely can catch this again. And I dread to think how I would feel if I did get it again. And that is terrifying. And I know no vaccination is 100%, but I still feel a lot safer for having had it.
And this is one of the real areas of interest for research at the moment. As Amy says, about a third of people who have their vaccine actually see no real difference from the vaccine, apart from that initial 24 to 48 hours afterwards, when they get their rather typical response. About 20% of people who have their vaccination actually get worse. And we've seen that quite regularly. They will see a significant deterioration in their symptoms. And that may be slightly higher with the adenoviral vector vaccines than it is with the mRNA vaccines. But that's the 20% who will be very vocal about being worse. There's another 50% or so who actually see a dramatic response to their vaccination. This is all based on a survey that we've recently done with 1,000 people in long COVID from the UK, from the States and from Israel. And we saw that within that population, for a period of between 28 and 35 days after a vaccine, more so with the mRNA than the adenoviral vector vaccines, that they saw a dramatic improvement, between 30 and 35% improvement in their symptoms. Many of them then started to slide back to normal at the end of the 28 to 35 days, but on their second vaccine, they received the same benefit. They also saw the benefit slightly better after that second jab. In the States or in Israel, where the vaccines were done 28 days apart, the vaccines saw sequential improvements, that we'd see a 30% improvement after the first vaccine. We'd then move on to around a 40% improvement from baseline after that second vaccine. Even for the population who got worse, this gives hope. There is no one size fits all in medicine. There is no single therapy that is going to make anybody better from everything. And therefore, what we really need to be looking at are the therapies that will work for the population as a whole. What we need to be considering is, what made half of the people get better? Can this be replicated? Should we be giving monthly vaccines for these population in order to get things better? That then poses huge ethical issues. With around 2/3 of the world no access to vaccines, should we be using the vaccines for those with long COVID symptoms when the disease itself is still spreading globally? Should we be looking at those who get better and those who get worse to see what are the fundamental differences? Can we be looking for other strategies to heal them? And actually, at that time, it's a great time to hand back to Parveen, because now we can start hearing from some of the research across the whole of the UK that is getting to grips with underlying causes of the disease, that's getting to grips with what are the differences between those who present with different populations, and hopefully start looking towards the potential cure going forward. Parveen, back to you.
Thank you, David, and thank you, Amy. David, that was superb, a wonderful introduction into what's going on. But I think you've given us more questions than answers. And Amy, thank you so much. It must be so brave of you to come and talk about your symptoms, which clearly were very distressing and continue to be so. So really most grateful, because I think getting that sort of live, program that you've been through and what's happened to you. And David then, of course, brought us more questions and terrified us a little bit more. Anyway, let's go to some research. So so we're going to have three quick talks, and the first one is Professor Jonathan Stern. Jonathan is Professor of Medical Statistics and Epidemiology at the University of Bristol, and I think, Jonathan, you're going to talk about research on long COVID in your Longitudinal Health and Wellbeing National Care Study. Thank you, Jonathan.
Thanks, Parveen, and thanks very much to David and Amy for that really fascinating introduction. So yes, as you can see here, I'm going to talk about research on long COVID in the Longitudinal Health and Wellbeing National Core Study, LHW-NCS. Now, I'm co-lead for the LHW-NCS, but as I hope will be crystal clear throughout my talk, I'm really presenting on behalf of a large team spread across UK universities and the NHS, and it's really I'm simply reporting on combined efforts and fantastic efforts from a large number of people. And the other great thing about that introduction is that it really explained the profound research challenge here, which is this is a condition that no one had even named a little over a year ago. And so we're trying to create definitions, services, and design treatment and manage the condition at the same time as we know very little about it. And so we're kind of building the airplane as it takes off. So I've mentioned the national core studies. Sir Patrick Vallance established 6 COVID-19 national core studies during the autumn of 2020 to really address the fundamental challenges of the pandemic, including epidemiology and surveillance, clinical trials infrastructure, transmission and environment, immunity, and data and connectivity, bringing together all of the key data sources to permit research. So we are one of 6 national core studies, and the aim of the Longitudinal Health and Wellbeing National Core Study is to understand the health, social and economic impacts of the pandemic by uniting established population cohort studies, so studies where we're following groups of individuals over time, with national anonymised health records. And so these are the substantial number of institutions who are collaborating within our national core study. And you'll see that we include the National Institute for Health and Care Excellence, NICE, and I'll mention that a little bit at the end. And these are the population-based cohorts from across the UK who are also collaborating in a really unprecedented way within the Longitudinal Health and Wellbeing National Core Study. And I'll be presenting preliminary results based on from these longitudinal cohorts, as well as from the unprecedented data sets that have been created during the pandemic, harmonizing population level primary care and secondary care NHS data. They include the SaIL data bank from Wales, the EVE2 dataset from Scotland, Open Safely, which has brought together data on up to 58 million people and produced a substantial number of profoundly important analyses, helping us to understand the COVID-19 and its effect in England. And the NHS Digital Trusted Research Environment brought together by Kathy Sudlow and David Seymour from HDR UK, which contains data on some 55 million people and was described in a recent paper in the BMJ. You'll all be aware of the substantial concern that was expressed over the last week over the patient opt-out. Now, we've all got comments on the way that this issue has been handled, and people's concerns, I think, are understandable. But I cannot emphasize too strongly that these new and unprecedented data sets have been of incredible importance in allowing us to understand the nature of the nature of COVID-19, its effects in the UK, and the trusted research environments within which these data are being analysed provide a way, in my opinion, to allow important research to happen while protecting patient privacy. I think there's a lot more to say about that, and maybe we could come back to that in questions. So we are bringing together the population-based cohorts and the linked NHS data through something called the UK Longitudinal Linkage collaboration, which is providing a national infrastructure for secure cross-cohort analysis on 1.2 million population participants in these deeply phenotyped population-based cohorts linked to relevant health and administrative records of relevance to COVID-19 research. That doesn't exist yet, but it will exist within a very few months and will underpin a lot of the work of our national core study. So our national core study has the 7 themes shown in this slide. And one of them is the longitudinal linkage collaboration that I described on the last slide. We're also looking at healthcare disruption, mental health effects, and so on. That there's been some really important work on vaccination. But obviously for this morning, I'm going to focus on long COVID. And our work on long COVID is through the separately or additionally funded convalescent study. That's coronavirus post-acute long-term effects, constructing an evidence-based convalescence, and that we hope will help define long COVID, its determinants and health, social and economic consequences to improve diagnosis, management and support. And it's a collaboration between the institutions and organisations shown at the bottom of the slide, funded, as I say, by UKRI, MRC and by NIHR. So it was funded for 3 years, starting in March 2021, and using this combined approach of established population cohorts and national anonymised electronic health records analysed in secure, trusted research environments. And we're conducting our research really in four themes, 4 work packages: defining long COVID, understanding risk factors for long COVID, looking at outcomes for long COVID, and then evidence for long COVID diagnosis and management towards the later stages of the project. And our aim is that these themes will allow us to create an evidence-based definition of long COVID and its subphenotypes, identify new and bespoke interventions to support people with long COVID, informed by better understanding of the mechanisms of these different phenotypes, inform interventions both at the time of infection and subsequently in assisting planning of healthcare services, and of course ultimately improve care and support for people with long COVID. From the point of view of and our research approach includes the things I've already talked about: analysis of existing data in national anonymised electronic health records and longitudinal studies, but also qualitative interviews of study participants, detailed phenotyping of long COVID cases and controls, say a bit more about that later, and piloting primary care record pop-up reminders for diagnosis and management in collaboration with NICE, and of course with participants and public involvement throughout the research. So from a patient point of view, we're aiming to answer these questions. Why do I have long COVID? What is it? Will I recover from it? How will this research help me? And how will long COVID affect my life? Now, this research is absolutely in its infancy, but it's already well underway, and I'm just going to give you a few selected highlights of things that we've already done. So early work has looked at coding of long COVID in primary care based on electronic health records of 58 million patients in the open, safely trusted research environment. And it's immediately clear that COVID varies hugely by varies hugely both by practice and by the electronic health record software provider, in particular whether it's TPP or EMIS. Only 20,000 patients, fewer than 1% of COVID patients, have a long COVID code in their primary care record. So there's a huge amount to do, even on beginning to understand who are the patients who have long COVID. In cohorts, in these deeply phenotyped longitudinal studies that existed before the pandemic, we've been looking at the prevalence and the symptom length. So we estimate the symptom length of 4 to 12 weeks, with a range of between 3.3 and 23.2%. More than 12 weeks, affecting 1.3 to 41.1% of patients. So you can see huge variation in the way the prevalence of long COVID is being appears depending on which data set you analyse. This work is absolutely in its infancy, and this slide shows the next steps. So in the cohorts, in the population-based studies, they're administering a standard long COVID symptom questionnaire with questions about long COVID and its functional and health outcomes. In these population-level electronic health records across the UK, we're going to be looking at the occurrence of signs and symptoms in broad disease categories after COVID. We're going to be looking in particular at putative pre-specified long COVID symptoms, as well as diagnoses associated with sick notes issued primarily in primary care, serious outcomes such as thrombosis and stroke, and doing text mining, for example, in the thin data set based on primary care electronic health records. Bringing all those together, we hope that we will be able to provide a far more detailed understanding of long COVID symptoms and their prevalence and their associated demographics, and then very importantly, how these symptoms cluster together so that we can start to find distinct long COVID syndromes and symptoms and phenotypes. Having defined those, we'll then be looking at their trajectories over time and how these relate to diagnoses in patients and at different stages of the pandemic. Of course, in the first wave, testing for SARS-CoV-2 was very restricted, and so we mainly know about people who ended up in hospital. Whereas in the second wave, we'll have much more detailed information on people who were infected but didn't have COVID, but didn't get hospitalised. These are the sorts of analyses we can do looking at risk factors for long COVID, bringing together both the meta-analyses of the cohorts and data from Open Safely, looking at the age distribution peaking in the 45 to 70-year-olds, consistent evidence that long COVID occurs more in females and in people with poor overall health and in people with poor mental health before they got their COVID, and more in people who were overweight or obese. Just at the bottom there, diabetes was mentioned during the initial discussion, and we can see that we've got some discrepancy between the cohort meta-analyses suggesting that diabetes is a risk factor for long COVID and Open Safely, which found something rather different. I think I'm running out of time, so I will skip over these risk factor analysis plans. Just to mention outcomes, this is an example of the amazing work that we can do using these population level trusted research environments. So this is Open Safely on 24 million people in general practices using the TPP software. Now these found much higher rates of the outcomes shown on the left: stroke, DVT, PE, heart failure, MI, AKI, type 2 diabetes, following hospitalization with COVID. But when they compared these outcomes with people who'd been hospitalized with pneumonia, I think that was 2019, they found these outcomes, although elevated compared to the background population, similar to people who've been hospitalised with pneumonia before the pandemic. And of course, we'll be building on these analyses using electronic health records and the cohorts. We'll be doing deep phenotyping using non-invasive multi-organ imaging and remote monitoring and wearables. Based on cases and controls, 200 in each group, defined by whether they've got a history of COVID-19 and whether they report long COVID. And this chart just shows that we're just getting underway. The documentation is with ethics, and we've started validation and reproducibility studies. Importantly, we'll also be doing longitudinal research. Yeah, I'll wrap up, but just to mention, we'll be doing longitudinal research, qualitative research, asking questions of patients about lived experience. And finally, we'll be working with NICE to ask patient-facing research question: how will this research ensure I'm getting the right treatment and support? And we'll be working with NICE to pilot embedded prompts in primary care electronic health records to increase compliance with NICE guidance. Sorry that was so rushed. I hope it's clear that we are on the start of a very long journey with all this. Thank you for your attention, and I look forward to the discussions.
Jonathan, thank you very much indeed. That was superb, but it does show how much more there is to be done. And I think it just also shows the importance of cohort studies and following them up. And I think that's where we're extremely fortunate having the NHS, albeit the data is not totally complete. But thank you very much. We look forward to hearing you later on. So we'll move on now to Dr. Claire Steeves from King's College London. Claire is a senior clinical lecturer and a consultant geriatrician, and she's going to talk about the attributes and predictors of long COVID and insights post-vaccination. Claire, thank you so much for coming. All yours.
Very good. Thank you very much. I'm just getting my speaker thing as it's just gone off my phone. Right. Very good. So I'd like to speak about a study that we've done since the beginning of the pandemic using an app called the Zoe COVID Symptom Study app. And what I want to sort of just give a brief overview about how we started this programme, how we went from a cohort study, which is part of the national core studies that Jonathan's just been talking about, to producing a national app, then using that to understand symptomatology in COVID, and indeed going on to talk about long COVID, because we could clearly track this using the app. Some data that we've now published within Nature Medicine about characteristics and attributes of long COVID, and then some further work that we've done since then in relation to vaccination. So first of all, talking about, I'm going to try and go to the next slide, but it seems to be a bit slow here. Here we go. So I've been working for the last decade or so with Twins UK, which is now part of the National Core Study on Health and Wellbeing, which Jonathan's been talking about. And we've been doing epidemiological studies using standardized questionnaires that we pass out to the cohort over sort of every year or 2 years. But when COVID came along, we felt that we could really do something different with this cohort, and we developed an app-based technology to really map symptoms within the cohort. But quite quickly, we realised that this would be very useful to roll out to the whole nation, and hence the COVID symptom study started. And the idea was really simple, that actually if we could use technology, digital technology, to map symptoms on a daily basis, or as often as people will log, then we can use symptoms to actually identify who might have a disease on a big population scale. And we did that very successfully. We produced a very now well-cited paper showing anosmia, one of the key data sets that really showed that anosmia was a very key signal of COVID. And using that data, we could then go to estimate prevalence within the entire population. But very quickly, we found that actually many people were having those symptoms of anosmia lingering for some time. And when we were trying to estimate incidence of new onset disease, we realised right back in April last year that there was a long tail in some individuals who continued to have ongoing symptoms. And so then we engaged with the Department of Health and Social Care, and they have helped us to get testing within all people that are newly symptomatic on the app. And that enabled us to estimate incidence, which has been very helpful in identifying hotspots and things like that. But clearly, we've been very interested in what was this long tail about. Just very briefly, obviously, it was really thanks to the citizen scientists in the UK, this population that was really thirsty for answers, that we managed to build a really big data set of 4.5 million people who are logging and have continued to log over the last year. And I'm just going to show you that that's the app. You may well be familiar with it, which initially people are asked to give in some demographic information, personal history, and characteristics, and then are given a daily reminder to put in test results, symptoms, and vaccination status more recently. And we've done a number of other surveys around behaviours, diet, mental health, and indeed, most recently last week, we've launched a long COVID retrospective app feature, which will be interesting in terms of relating to the data that Jonathan's been showing you in terms of the cohorts. We've now, so I can't quite see the side of my slide here, but it's something like 4.6 million primary loggers in total, of which a certain number are participants reporting by proxy, but we still have over 1 million people that are active on a bi-weekly basis on the app. But we're not a nationally representative study, and so all our analyses have to take that into account as limitations or using statistical methods to adjust for that bias. But it's really a very large data set, and we have, its majority is in the UK, but we've also recapitulated studies across in the US, where we have individuals on the app as well, and in Sweden, and that's relevant to this discussion about, is long COVID just a UK feature, or is it something that's international? Trying to go to the next picture. Right, so at the beginning of the pandemic, we were interested in what the symptoms are that are associated with COVID-19 disease, so associated with positive testing using this data set, and what then in those symptoms in the first 5 days might then go on to predict who's going to be hospitalized. And so here you've got some heat maps which show symptoms across the day. So the very left-hand side of each of these little heat maps is the first day of symptoms, and then it goes up to about day 10 on these. And you can see that using machine learning algorithms, we could identify that there were 6 different clusters of symptom presentation at the very beginning of clinical disease, and these were related to the later need for respiratory support in hospital. So that if you were in cluster 5 or 6, which predominantly was older people and people with comorbidities, they were enriched in these groups. Those people had a large number of symptoms, and in fact we could then produce a computer algorithm which said actually at 5 days, if you had more than 5 symptoms, and including your age and BMI, you were at higher risk of need for respiratory support. So that was sort of, in a sense, an indication that complex multiple system disease right early on had repercussions in terms of acute disease. So then, as soon as we were starting to look at this tail, we're really interested in whether or not those symptoms are again multi-system in long COVID, and how those early symptoms relate to disease later on. And so we looked at a very carefully chosen subset of people on the app. And remember that selection is because we really wanted to be absolutely sure that symptoms that were being reported in the context of COVID illness were due to COVID illness. So within this analysis, we subsetted by people who reported no symptoms in the 2-week period before they got their onset of symptoms around the COVID positive test. And there are about 4,000 individuals on the app that met those criteria. And we had a look and see how long do those symptoms last in comparison to somebody who had new onset symptoms, but at that same time had a negative COVID test. And we chose age and sex matched individuals. And so in this graph here, you can see the blue line, which sort of like rapidly goes down, that's individuals that are negative for COVID. So most of them are finished with symptoms really in the first 10 days. There are very few individuals that have a similar respiratory virus, but it's not COVID, they test negative. Those people, very few of them have symptoms for more than 28 days. But when you look at people who tested positive, we saw this tail. So you can see that there. And it does go on for quite a long time. And there is a small proportion of people, and we can see them on the app, that have symptoms seriously for more than 15 months now. There are some people that are in that category. But overall, across this big population, we found these rates of individuals with symptoms for more than 28 days continuously. And of course, then we looked at whether those individuals were then more likely to relapse, and indeed they are. And that's the thing, that's what Amy was talking about before, that these symptoms don't just go on for 28 days, they then can maybe go away again and then come back again. What were the symptoms that were found? Well, we've already talked about this, but what Amy's been saying is really played out in the data, that really the most common symptoms are this fatigue, headache, shortness of breath, loss of sense of taste and smell, which continues, and cough. But there are a wide range of other symptoms that are also experienced, as we've demonstrated. But bear in mind that this early data was using symptoms that we put on without knowing about long COVID. And we've used this information with the app to really understand from participants what are the symptoms that they are suffering, because they can report those in free text. So looking at that, the free text analysis of responses revealed this disproportionate number of cardiac symptoms, of palpitations that Amy's been describing is really represented within the app data, but also neurological symptoms emerging. And we've put them into the app, and now we're analysing all the information around the second wave, so that we can see a little bit more detail what symptoms people overall as a population are describing. But using the app, the data that we had before, we could see two clear different clusters of symptoms. One which is very multi-system, and one which is predominantly fatigue and respiratory symptoms. In terms of age, I noticed, David, that you said that long COVID is a feature of young people. Within our data within the app, and also recapitulated within the national core studies, we see a very clear age gradient actually in long COVID, that it is more common in that 60 to 70 age group, and then probably reduces, as open safety data showed, reduces in the very older individuals, but there is a gradient that increases through time, through age, and that's not related to the incidence of COVID itself, even if you correct for who gets COVID. And in fact, older people are less likely than younger people to get COVID because of shielding behaviour. But even if you correct for that, you still see an age gradient, which may be important in terms of our understanding of what is actually going on within long COVID. So do you remember I showed you those heat maps looking at how early symptom aggregation might relate to future need for hospital support? So we looked to see whether the same thing was the case within long COVID, and indeed it is. The very strongest feature within machine learning algorithms that predicts long COVID is actually the number of symptoms that someone experiences in the first 5 days of illness, and coupled with age and sex. And actually these sort of nomograms were very accurate at predicting who might be at higher risk of going on to get long COVID. And the reason why we're interested in that was because that potentially might be a potential avenue for prevention. Now, more recently, we've looked at how the vaccine might be working in terms of infections people have gotten after vaccination. So is this going to be such a big issue for individuals that get COVID after a vaccination? That's different from what David was saying earlier about the effect of the vaccine upon somebody's symptoms who already has long COVID. The good news is that certainly in the older age group who are most at risk, the 60 plus, the risk of long COVID, if you get infection post-vaccination, is reduced. But that is additive to the obvious, very clear reduction in risk of COVID infection itself. So we think that long COVID is going to significantly reduce. Trying to go on to the next one. In terms of new work that we'll be doing, we're going to be looking in detail at definitions of long COVID and cross-correlating information from retrospective questionnaire data with symptoms that are logged regularly on the app, because obviously they may differ. We're going to be looking at what David was saying, that the long COVID SOS group have identified that some people get worse, some people get better post-vaccination. That's something that we are certainly finding within our data set. We're really trying to understand whether those different people are characterized by certain differences. So we'll be looking at that. We'll be doing further analysis of the symptoms that people are reporting on the app and that we've been collecting. And we're looking at biology of COVID. We've subsampled a selection of 8,000 or so individuals that have different types of long COVID logging. And we have already sent off analyses for genetics, metabolomics, and so on. And we're doing clinical studies in those individuals as well to really understand differences in symptomatology with these very carefully phenotyped individuals. And if I can have the next slide, that would be great. There we go. So our data is shareable and accessible, and do ask if you wish to have a look at our data. We've produced a lot of papers and preprints on symptoms, and obviously there has been a big team involved. Thank you very much.
Thank you, Claire. That was lovely. It's interesting. We've had cohorts, now we're having apps telling us where we should be going, and actually, does actually spend some time telling us where the disease is and the progression of the diseases. I'm delighted you're disagreeing with my co-host, David. He's just posted to say young for him is 65 as he's a geriatrician. So perhaps you ought to say exactly what young means. For me, it's probably under 80. Anyway, thank you very much, David. We'll hear from you later. So we're now moving on to Chris Breitling, who's from the University of Leicester. Chris is the director of the Institute for Lung Health. He's a researcher and a consultant respiratory physician. And Chris, you're going to talk about long COVID post-hospitalization, the FOST-COVID experience. I'm sure you'll explain what that is. Thank you, Chris.
Thanks very much. It's been a terrific meeting thus far. And I think actually the fact that the community has really come together from a research perspective to really try and understand and tackle this problem, I think is really a testament to, particularly in the UK. So FOST-COVID is the study that's really focusing on people who've been hospitalised. So what we have is a national consortium, which is over 50 centres. And what we're looking at is really to then establish our understanding of the patients that have then been discharged with COVID-19, understand the mechanisms, and then ultimately really try and then improve their care. We focused on people who were hospitalised in part because at the start of the pandemic, clearly only those people who were in hospital that were actually being tested for COVID-19, but also that we had considered that this might be the population that would have the largest burden of disease after they were discharged. And you can see from these data that were a snapshot taken from May that there are about 500,000 people who've been admitted into hospital with COVID-19, and clearly there's a much larger population that are then being managed in the community. We recognise that this condition needs to have parameters by which we then agree how to define it, and the NICE guidelines, which you've heard discussed already, then include the acute episode, the ongoing symptoms, and that post-COVID-19 syndrome, and long COVID, which was really coined by patients, and I think therefore actually the term that's most used and probably best actually, I think, includes those with ongoing symptoms and the post-COVID syndrome. So let's try and think about where FOST-COVID actually sort of fits into this map of research. So you've heard about some of the population studies, such as Open Safely, and then also the ONS data. You then have the acute platform, which has very much been the ISARIC observational study. And then other people who are then in follow-up after hospitalization includes the FOS-COVID study, which I'm going to tell you about, but also other studies which are very closely linked in the immunology, genetics through genomic. There's a COVID CNS study and also a specific pulmonary fibrosis study. These link into the intervention studies, such as the recovery remount cap, in terms of being able to understand outcomes from those studies. And we're also linked into the community COVID studies from the core studies that you heard about, with common outcomes that are being measured between FOS-COVID and those studies, and such that we're going to be able to then make some cross comparisons. All of these studies also inform policy guidelines. They're important in terms of health services research, and we link in also with industry. And it's going to be important there as well to be thinking about how they can help in terms of further tests and also potential interventions. Obviously, COVID has affected the world, so there are similar initiatives that are then ongoing across Europe under the banner of the European Respiratory Society, and also other activities that are going on across the world through WHO initiatives. And certainly FOS-COVID is very much positioned and linked into those. So what does FOS-COVID actually aim to do? Well, the three aims are very straightforward. So the first is actually to try and understand what are the mechanisms that are driving the post-hospitalization long COVID. So why is it some people recover quickly? Why is it those people who develop health problems later on? What's the impact of the interventions in the acute stage? So is there actually already therapies that might impact on long COVID? And then thirdly, we wanted to use the platform to then actually be able to call patients back, where we wanted to study in more detail, and also then to be able to layer on experimental medicine studies where we can then start to look at interventions in this population. How are we doing this? So I've already said that we have many centres that are recruiting the patients. It initially was 50. We've now recently elevated that up to now 80 sites across the 4 nations. Scientifically, we're then very much anchoring our ideas around the patient in the centre. We appreciate that there's a need for a modular approach to clinical care and phenotyping, and therefore that's reflected in our working group structure, where we have a number of very active working groups with contributions from patients, charities, and then a very active PPI group and a group focusing on ethnicity, social science and health economics, and then a series of platforms that are then supporting the research. Overall, we're recruiting 10,000 individuals. 7,000 of those will be in what we call Tier 1, which will be focusing very much on existing data that's collected routinely. 3,000 will then undergo a very detailed assessment, which I'll come back to in a moment. And then Tier 3 is really then focused on that recall and those more bespoke studies. So in Tier 2, we have an in-clinic assessment. So this is really one of the major differentiators between FOS-COVID and many other studies, in that we then are seeing patients at approximately 5 to 6 months and then also at a 1-year follow-up. So in that assessment, we're asking patients very simply, do they feel fully recovered? We also have a very extensive symptom and questionnaire portfolio of tests. We are also then looking at physical performance. We're undertaking breathing tests, blood tests, and we also have a suite of imaging, which includes clinical imaging, but also CT and MRI. So in terms of MRI, we're very closely linked, and in fact Seymour is now part of a Tier 3 study within FOS-COVID, whereby we're looking at multi-organ, multi-modality MR imaging. So we're getting information about changes on the MR scans in different organs. So I'm showing you here data with healthy controls versus those patients with early scans after they've been discharged. And there are differences and changes in the brain, the liver, the heart, the kidney and the lungs. And the summary I'll just show you here is then the proportion of patients that then have abnormalities in those MR scans, and are as high as 60% in the lungs, about a quarter in the heart and about a quarter in the kidneys. So really important to see that there is some changes in the end organs in those patients. First 1,000 patient data has been reported as a preprint and was picked up by the media nationally and internationally. And this included just over 1,000 patients with a mean age of 58, predominantly male with mixed ethnicity. A large proportion of those were still working, so that's 68%, and over half were obese with a BMI greater than 30, and a number of them had co-existing conditions. In terms of the the results, what we found is that we actually had included a really quite wide spectrum of patients in terms of their severity when they were admitted, including those that were on supplemental oxygen alone, through to those that were in intensive care and had mechanical ventilation or ECMO. We also had patients who were treated with steroids, antibiotics, and anticoagulation acutely. If we then actually asked the question, well, do you feel fully recovered? And in fact, only 30% felt fully recovered. So 70% did not feel that they were back to normal. They had very large numbers of symptoms, but the median number of symptoms was 9. 18% were no longer working, change in their occupation, and 20% had a definition of a new disability. We found that there was considerable morbidity, so about a quarter of the cohort clinically significant anxiety, depression, changes in terms of cognition, post-traumatic stress disorder, and really quite substantial impairment in terms of their physical performance. As has been shown before, you can also then look at what are the risk factors around recovery and therefore persistence of long COVID, and we certainly did that. And again, I'm showing you data on age, where we found that those patients that were at highest risk of having long COVID were in that, I'm going to use the term middle age, so that's sort of between the ages of sort of 35 and 65. And we also found a predominance in females rather than males. Obesity, comorbidities were also risk factors. And interestingly, treatment with steroids or antibiotics at the acute episode really didn't seem to make any difference to the symptoms of long COVID. We also took the data that we got from those standardized questionnaires for breathlessness, fatigue, anxiety, depression and post-traumatic disorder, as well as cognition and physical performance. And we used those to put them into a cluster analysis to then try and see if we could identify groups. And we found that we could identify 4 clusters, and 3 of those were very concordant in terms of the severity of symptoms and physical performance, and really mapped out on severity. But one was discordant with a really quite marked feature of cognitive impairment. So if we plot those in 2 dimensions, then we can then plot them with the concordant symptoms against cognitive impairment. And then we very simply describe those clusters as very severe, moderate, which has this impairment in cognition, or as being termed brain fog, and then a milder group, although remember this is still a group that has impairment compared to people without disease. So we're then finding that there's female predominance in those more severe clusters. Obesity is more of a feature in those clusters. And we're also finding that not only are they the ones with the greatest impairment, but they also have elevation in inflammatory markers such as CRP. And certainly one of the strengths of FOS-COVID is our ability to now be able to look in tremendous detail around a number of features biologically, looking at autoimmunity, protein multiplexing, and looking at microbiome across all of these individuals, and then also linking into their genomic and gene expression. So then how does that fit in with what we understand in terms of studies that have been undertaken elsewhere or before? And if we then look across what's already known, then the very early study that was reported just on some symptoms at the 2-month point from a single centre in Rome, that about 87% of the patients hadn't recovered at that point. About 74% in this single centre study from Bristol. And then data from the French cohorts identified at 4 months around about 51% hadn't fully recovered. And then these are the data from FOS-COVID, and then also the data from the Wuhan Center in China. So it seems that in taking those studies as a whole, then somewhere between 50 and 75% of that sort of 6-month time point is still not fully recovered. So in fact, the majority is still not fully recovered. And then data at 1 year is beginning to emerge, but really hasn't yet started to nail down the rate of recovery in that trajectory of disease. And that's going to be really important over the next few months. So then if we think about then summarising what's then our understanding of the legacy so far, then the majority of people that are hospitalised and discharged with COVID-19 then still have impairment. And this is also true that there's a problem in community, although it seems to be the minority at that 6-month time point. There's a very large range of symptoms, and this really comes back to that need for multimodality, multi-system approaches in terms of trying to understand the condition and thinking about physical and mental health then going together and actually thinking about how you then introduce personalised interventions, taking into account all of those different domains. So therefore, there's really a very urgent need to try and now understand the mechanisms much better to then really identify which interventions might be suitable for which groups of patients. To undertake this study, there's clinical groups running the long COVID clinics in each of the centres, and I'm just showing you here on the top left the people that are running the COVID clinic within Leicester. There's a similar number of people who are then running the research programme alongside the clinic, and this is replicated in every single centre. So obviously I can't show you pictures of everyone. I'm showing you Rachel Evans and Louise Wayne in the bottom left, who co-lead FOSCOVID with me, and Artie and Ananga, who have been absolutely phenomenal in driving the clinical and management of the project as a whole. And this has really been possible through support from the patients, patient support groups, charities, and also funders, and really the tremendous effort nationally across all of the centres to really contribute to this study, which is really just beginning to give us more information about long COVID. But I think there's so much more to come, so much more we can give, particularly around trying to unpick some of those mechanisms and working towards personalised therapies. Thank you very much.
Thank you very much, Chris. That was superb. Also, I mean, just the amount of work that all of you are doing is just quite incredible, and it seems to have taken off so much quicker than I think most other sort of diseases. So it's wonderful and nice to see the collaboration across not only the country but internationally as well. And also thank you for highlighting the cognitive impairment that a lot of people have. Thank you very much indeed. So David, a list of very lovely research that we've heard. Over to you for an interesting panel discussion.
Thank you very much, and again, thank you to all of our speakers. I don't know, can the tech people bring us all up onto the screen? So then we can start putting, people are hiding. And actually, I'm going to take a question first that actually has been put in by 3 or 4 different people, all looking at a similar sort of phrase. And it was directed at me, which is always a pain when you're the chair, and talking about whether the learnings from chronic fatigue syndrome and ME are being translated to long COVID, and similarly another question about the research integration. So I'm very quickly going to say that yes, there is lots of collaboration going on with the CFS ME community. Indeed, our genetic study, we are aligning with Decode ME, which is a genetic study looking at ME to try and look at the similar identification of the genetics to see if this is effectively one disease that is spread along multiple different presentations. And there's a lot of people who do believe that patients with CFS and ME have got a post-viral syndrome very much akin to this. And actually the vaccine study that we did have a cohort of people with CFS and ME, and interestingly 20% of people with CFS and ME, 60% of people with CFS and ME saw a 20% improvement with their symptoms with a COVID vaccine, which in itself is hugely interesting, although we're not quite sure what the next step of these data would be. So having spoken enough about my own bit, the next one I'm going to put to Jonathan. There's a question from how we should be interpreting the use of these data. Should we be going for opt-in from patients, or should we be looking at an opt-out approach?
Very, very good question, and one obviously a very much matter of current debate. My personal view is that an opt-in approach simply would not work. Now, you might ethically decide that the only ethically appropriate approach was opt-in. But I think if you did that, you would end up with if you required active opt-in, you would end up with a very small fraction of the population. And remember that having near complete population coverage, including from some groups that may be harder to reach, has been fundamentally important. One obvious example is that Open Safely were able to identify early, first, that there was increased vaccine hesitancy in particular ethnic groups, then that vaccine uptake was lower in particular ethnic groups, and that led directly to interventions to improve uptake in those groups. Now, if those sort of analyses with immediate implications for care can only happen with complete or near complete population coverage. So I don't think, I think an opt-in approach would substantially, would be very problematic. Opt-out is clearly essential. I mean, in the end, if somebody says, I don't want you to use my data, you have to allow them to say, I don't want you to remove their data. So I think the question is, how do we communicate the benefits of these trusted research environments, the safeguards that are in place, and therefore minimize people's wish to opt out? And that's a matter of active debate. But the basic point is that detailed data are disclosive, and these trusted research environments are set up to prevent people identifying individuals and exporting information from them. So you have to recognize that the opportunities of these data absolutely do entail risks of violation of privacy, and then set about designing systems that mitigate as far as possible those risks. I think that's been done. I think it does constrain what you can do, and I think it's vital that it's communicated that way, and it hasn't been communicated yet, or at least not completely.
Thank you, Jonathan. So we have another question on here that has come from somebody who hasn't actually put their name to it. So if you're putting questions to, please do put your name to it so we know who's asking the question. It's a question I'm going to throw to you, Claire, and it's talking about ethnicity. We know with acute COVID infections, there was a disparity with more hospitalizations and death in different ethnic groups. Are we seeing the same sorts of things with long COVID?
Sorry, just unmuting. That's a very interesting question, David. And we have looked at that within the app data, and we found no significant increase, or no difference that we could discern between ethnic groups. And noticeably, we had the hypothesis, as I think your questioner does, that maybe there would be disproportionate long COVID in individuals of non-white ethnicity. We didn't see that. Within the National Core Studies group, we've seen quite convincing evidence of actually a reduced risk within non-white ethnic groups. Of course, there will be, very different potential influences of different ethnicities. And I think this is going to be an area of really increased interest. There could be two reasons for that. One might be a different cultural response to the symptomatology and a different labelling of one's own symptoms. Or willingness to come forward. And the second is that there might be biological differences. And I think that both of those things are possible, as is no difference at all still.
Okay, thank you. So we got another question here from in Sydney. We are hearing from St Vincent's that the long COVID patients are all receiving an MRI and spectroscopy, which is showing differences in the front matter. Chris, do you think this is something we should be doing at least in our post-hospitalised patients or in the population as a whole going forward? And do you think that would feed into the evidence that you're already seeing coming out?
So our study Seymour that I described is now actually undertaking multimodality MR in just over 300 individuals, and these tests are complex, they're expensive, and they're also quite timely in terms of them doing the analysis, translating them immediately into routine care. Really try and explore much of the content of those studies show.
We lost the sound on that towards the end. I don't know if that was just me. Could you just possibly repeat that last?
Yeah, sure. I was also, I wasn't sure if it was me as well. So what I was saying is that in the Seymour study, we've now done multimodality MR in 300 individuals, but it's quite a burden on patients. It takes quite a lot of time to then do the analysis. and it's not inexpensive. So I think rolling it out as a routine test yet is probably not the right thing to do, but certainly understanding what that tells us is going to be really important. So I'm really excited to see what the further data is, and doing that as a trajectory. So actually trying to understand, are the changes that I showed in that small pilot study very early on at a couple of months, are those findings still persisting in 6 months and 12 months? And that will start to really help to answer the question that you've asked about whether we need to identify these things early or not.
Thank you. Next, I want to give a question to you, Sally. There's a great question here talking about how much of the learnings for the treatment of long COVID have come from the learnings of CFS-ME. Did that give you a good starting platform for creating this app for?
We certainly, when we were developing the Your COVID Recovery, were very mindful that fatigue was an important symptom, and actually worked with fatigue experts, because traditionally within the field of pulmonary rehab that we've not focused on that as a symptom, but we worked with psychologists, psychiatrists, occupational therapists who had a huge amount of experience in fatigue management. And I think one of the challenging areas is this conflict between exercise and chronic fatigue. So we trod extremely carefully when we were proposing that as an intervention. But we followed basic principles as you would for somebody that was breathless. So the teams that are offering rehabilitation have a huge amount of experience in working with people with a different symptom and working within the limits of that symptom. So we transferred a lot of that knowledge over to managing patients with fatigue.
Had to happen sooner or later, I'm sorry. So actually, there's a quick question that was asking for clarification from one of the things I said about our long COVID SOS study looking at vaccination. It was 57% of people who had long COVID got better after their vaccination. That was actually 54% with the AstraZeneca and 63% people who had the mRNA. Subtle differences. 20% again made up of 14 and 21% for the mRNA and the AstraZeneca got worse. The third in the middle, actually, apart from their acute effects of a vaccine, they saw very little difference. But I want to stress that is a survey. It comes with lots of limitations. It's not systematic. It's based on lots of reporter bias, and we all know people are more likely to respond to a survey if they notice a change, whether that be for better or for worse. And that's why these things need to go out systematically. So a question I want to throw to you, Amy. This is a question that's come from, I've just lost the thing. I think it was a Sarah. Oh no, sorry, an anonymous question, Amy. It came through asking about GPs facing people who were not hospitalised for long COVID. Is this something you're seeing both in your primary care setting and your own experience, that GPs who are seeing non-hospitalised COVID and are then reluctant to make a diagnosis? And this is particularly true for those who actually don't have a confirmed diagnosis for long COVID in the first place, so for acute COVID in the first place with a PCR or flow rate. What advice can we give to our GP colleagues out there who are seeing these patients?
I mean, the NICE guidance is quite clear that we don't need to have positive swabs, we don't need to have antibody testing, and that it is done on a basis of a collection of symptoms once other illness has been ruled out. So there is a new RCGP module coming out, if it hasn't already been released, about long COVID and what it is, and all of this is included within that. There are various different articles that have been published in the BMJ. Trish Greenhouse did quite a big one a while ago that suggests various tests and investigations that GPs can do, and it always stipulates that we do not have to have been hospitalised, etc. So I think if patients are coming up against that, it might be worth just gently nudging them towards these articles that they may not have had time to read. You know, this is a new illness. everyone in the NHS is absolutely drowning at the moment and treading water, and people aren't necessarily having the time to go out and read about this. And long COVID may not be on everyone's radars. Us who are knee deep in it, of course, that's all we think about all day long. But for the majority of our colleagues who are dealing with everything else currently, it might not have hit their radar yet. So I think there are things that we can gently suggest that they look at, the articles that we can bring that have been widely publicised and available. And NICE guidelines is very clear that this, hospitalisation and positive swabs do not need to be there in order to make the diagnosis.
Okay. And then following on from that, we're talking about clinics and developing a service, and has put a really good question is, should we be developing functional medicine specialist services to address the multi-system nature of COVID? We tend to have a very mono-organ focus to medicine these days, and I'm going to throw this to Claire as a fellow geriatrician, because we are very used to working in multi-system failure. Claire, what are your feelings on this going forward?
Yes, that's right. I think it's a very good point, isn't it? Long COVID is a multi-system disease, although of course individuals with long COVID may have specific systems that are affected. And so for an individual, perhaps like Amy, who's really got a characteristic POTS syndrome, which is maybe driving most of their symptoms, it's very appropriate for that person to see somebody who's specialist in that area. Having said that, many other individuals have multiple different systems, and if people are going to have to go to see multiple different professionals, that's clearly going to be very burdensome on individuals that have fatigue, and it's also going to lead to multiple different doctors having different suggestions and treatments. So I think that it's definitely true that we need to continue what we are doing, which is bringing professionals together so that they can identify and treat individuals as a group within an MDT type setting, but also all of the doctors and individuals that are looking at need to be thinking holistically about the patient. And that's not, you don't have to be a geriatrician to be doing that, or a GP. It's a mindset that actually will really help other management of other conditions as well, because all diseases are holistic in the end, and all diseases need a multi-system approach.
Thank you. So again, everything is multi-system there, and they're highlighting the importance of that single approach looking at multi-system disease. And we've talked a lot about the long COVID patients and the hospitalized patients. Do we have a ballpark figure for how many people developed long COVID who were not hospitalized? I think, Jonathan, your research into the databases is probably going to be a good starting point for this. And I'm going to come to Claire with some of the problems that's faced in a moment. On mute, Jonathan. It's not just me.
15 months since the start of pandemic and counting. In terms of a definite answer, Claire's going to have, I think, probably going to do better than me. But I mean, I think we've all stressed the extraordinary novelty of this condition, how recent it is that there's even been a name for it. And in understanding the relation of long COVID to non-hospitalized patients, remember that in the first wave, we're going to have a whole bunch of people who had symptoms but never even tested positive. So confirmation simply wasn't available. So it's going to be really interesting to look at what happens with symptoms and diagnoses of long COVID among people in the first wave who think they had COVID, but we'll never definitely know, and compare that with people in the second wave starting in September, October 2020, again much more recently, so limited data available to date, for whom I think a large proportion will have tested positive. So we'll be much clearer on people on who had at least had a positive antigen test. So we will get to understand these things, and understanding the extent to which there are symptoms that are related to having had COVID, by contrast with having been hospitalized for a serious infection, I think is going to be really important. I've got no more specific information to offer, but hopefully Claire can do better.
Claire.
Thank you. Yeah, so actually this is a very difficult and interesting question, and it depends on how you define symptoms, because of course many people have symptoms anyway that come and go over time from many different diseases, and they in a sense are in there when you're looking at symptomatology in a big population. And so, for example, we've looked within the cohort studies and we see about 30% of individuals have symptoms that come and go, yeah? But nevertheless, in people who are not hospitalised with COVID, the number of people who have symptoms that is reported for any reason is increased. Now, if you then ask individuals and patients, actually, how long do you think your symptoms that you think have come from COVID, how long do you think they last? We find around 10% of individuals within the cohorts and within the COVID symptom studies app as well have symptoms for longer than 12 weeks when considering ones that come and go as well. So I think that's the order of magnitude that it probably is. And because many people had COVID and were not hospitalised, therefore it is a significant number of people within the population. But I just would bring up the other thing, and of course that we do know from open safety data that there's a very clear increased risk of other diagnoses such as cardiac disease, pulmonary embolism, diabetes. New diagnosis of diabetes there's an increased risk of those diseases if you had COVID. And so other diseases may come in as well and may cause symptomatology changes, which is slightly separate from long COVID. But also that may be partly why it does appear that GPs are still unwilling to make the diagnosis of post-COVID syndrome. And we've seen this by the fact that the open safety data coming from both EMIS and TPP show really very, very much reduced sort of frequency of long COVID within people who've got a known COVID diagnosis. And I think that means that GPs are still not pressing the buttons to say this is post-COVID syndrome. And that may be partly because they're in the process of investigation of other causes, or it might be because there's still reluctance on the part of GPs to label this disease.
It's also slightly more complicated by the fact that long COVID isn't actually the SNOMED code, it's the post-COVID syndrome. And actually that was first instigated in January, but there are likely to be a whole series of new SNOMED codes that are very slightly different based on the different international definitions of long COVID. And of course, we have to make SNOMED internationally compatible. And I think that is possibly making GPs' lives a little bit harder. And actually, thank you for including that, because you did touch on another question that was coming up, who asked whether COVID itself was a cause of diabetes, or whether we're just catching up on the backlog. And as you rightly say, we know coronavirus does affect the ACE2 enzyme on the beta cells, so it was causing an acute type 1 type picture of diabetes, but afterwards its vascular impacts are increasing insulin resistance, so we are seeing number of type 2 diabetes patients going up. So I've got a question that I want through to Chris, and actually we've got two very similar questions. One looking at one asking about, do we see permanent pulmonary fibrosis in the post-hospitalization patients on CT, and a similar question about the post cardiac MRI scans. Are we seeing evidence of permanent damage, and if we're seeing them, what should we do about it?
So for the pulmonary fibrosis, the best data so far actually is from Wuhan. So they've reported in Lancet Respiratory Medicine this month that a small number of patients, it was 80 patients that had follow-up in terms of their pulmonary function tests and CT scans. And a quarter of those had impairment in their diffusion coefficient. But on CT, although a quarter had abnormalities on their CT, they didn't actually identify any that had established significant pulmonary fibrosis at 1 year. So although a small study, I think that's actually quite reassuring. And what we're doing in FOS-COVID is then linking all of the clinical CTs that have been taken post-hospitalization, and that will also then help to confirm or refute that early finding that's come out of the Wuhan data. With the cardiac data, there's also another study called COVID Heart, which is actually then looking at cardiac MR specifically, and that will be reporting further data shortly. And similarly with our data in Seymour, we'll then be able to see better as to what the impact is of 1 year. I'm not aware of any reports yet on 1 year data with any cardiac MR. So reassuring from pulmonary fibrosis thus far, and more data to come in terms of the cardiac abnormalities.
Thank you, Chris. We've got a series of very pragmatic, practical questions coming along, and please do keep your questions coming in, and please remember to upvote them, because we are picking from those that are being upvoted the most. So a question to Sally now. You've done a brilliant job of describing the Your COVID Recovery app. However, very pragmatic question. How do patients get access to it? Is it copyrighted? How do we actually get people onto it?
So the first stage is completely open access, so that's available to everybody. The second stage, which is the interactive stage, requires you to have been seen by a healthcare professional for all the reasons that we've talked about, to screen out other medical problems or the need for additional investigations, and then patients can be referred into however your system is organised locally to deliver that. So we've trained about 100 sites at the moment. We'll probably train more. It's probably available on about 100 sites, and they're an enormous variety of rehabilitation programs, IAP services. Some primary care services have decided that they want to run it independently for their cohort of patients. So I think people are really feeling their way as to what this pathway may look like. It's free to use for anybody that wants to use it. We have all sorts of data protection agreements, as you might imagine, that needs signing off first, but we've worked with NHS England and their legal teams, Caldecott Guardians, etc., to get those right. So it should be a fairly smooth process, and then the team in Leicester will offer training for the sites that are delivering it, because quite often staff aren't as digitally competent as we think they might be. So we train staff how to use the programme and track patients and respond to patients' emails. So it's not a standalone app with no support. There's no requirement to have synchronous engagement with patients. So you cannot, we just ask that patients' questions would be answered or turned around within 48 working hours. But otherwise, it's quite a light touch intervention, and it has embedded in it the EQ5D and quality of life measures. So we should begin to get some data from it soon. But if anybody wants to use it, feel free to email me, or there is a link actually on the Your COVID Recovery site to email in if people want to get access to the more bespoke site for patients, and we will very happily train whoever you nominate, or indeed yourselves, to manage it.
I'm going to preempt a question to you, Sally. Is it available to our colleagues north of the border? I'm saying that looking at Amy in the centre there.
Not directly, because NHS England funded it, although NHS Scotland have been talking to us about re-providing it in Scotland and sort of redressing the site so it has a more Scottish feel than the blue NHSE logos. So that, I think that would be very much a work in progress at the moment.
Okay, I got that one in there for you, Amy, because I know we were talking about this. So, Amy, I am going to come to you next. And I've actually got two related questions. The first is a very simple, pragmatic question from one of our watchers who's potentially dealing with patients with a similar condition to yourself. How much of the propranolol or the bisoprolol did it actually take to fix you? And then afterwards, I would like to say, there's a great question here, is what is the most useful action a GP can take when looking after a patient who's potentially got long COVID?
So the bisoprolol, I'm trying to remember back actually, because I ended up stopping it because I got side effects and was moved on to ivabradine, which is another known treatment for this. So I think I eventually ended up on 5 milligrams of bisoprolol, although from what I understand from POTS experts, you can pretty much for want of a better word, mess around with the dose according to your symptoms. So some people do take it quite variably. If they're having a day when they're feeling worse, they take more, and if they're feeling a bit better, they can take less. Certainly with my ivabradine, I started off on 2.5 milligrams BD, and I've gone up to 5 milligrams BD. But I know that if I'm going to go out, I've just restarted jogging again, doing couch to 5K at my own pace. And I know that if I'm going to go out for a run, I probably take my dose a bit earlier so that I take it before my run and dose up on electrolytes prior to that. And if I need to, I might take an extra small dose in the evening if I need to. So it's quite nice that you can mix and match according to your symptoms with meds. That's something I've learned from POTS UK. What can GPs do? I think the single best thing a GP can do is listen, particularly for the patients from the first cohort who have felt very alone in this, have really been having to self-manage and do this on their own and have been terribly scared. Like many of us, we sat at home and dealt with this illness. In the early days, we were breathless, we watched our stats drop. I have colleagues who wrote goodbye letters to their children. You need to listen to these patients. So giving them the time is the most important thing. Acknowledge their symptoms, believe them, validate what they're going through. Unfortunately, there has been a fair amount of gaslighting going on across the board, not just from GPs, but from specialists as well. And that's incredibly upsetting and demoralising, and you lose trust. And a lot of people have lost trust in clinicians over this. And I think that's what's very important. And then I think as a GP, it's very overwhelming when you're faced with a patient with a multitude of symptoms and you've got 10 minutes to rattle through it. And I think as a GP, don't be afraid. There is so much you can do. Break it down into systems, go back to basics, and you will be able to support them when you take the time. And you won't be able to do it in one consultation. You need to develop that continuity of care. NICE guidelines clearly state that. You know, bring the patients back, see them regularly, deal with the questions as they arise in a system-based approach, and you'll be winning.
Okay, so I've got a question I'm going to throw to you, Jonathan, with the expertise on the databases. There was this press release yesterday that came from the NHS, this question from that suggested that there is going to be a new service for long COVID in younger patients. I'm assuming that means youngsters, as opposed to me as a geriatrician, which thinks anybody under the age of 80 is young. It cites a figure that there's 340,000 people who need support and 68,000 who are going to need rehab and specialists. Are these numbers that we are seeing, are we expecting these sorts of numbers to grow amongst the youngsters? Jonathan, and then possibly Claire, to the same question.
And he's unmuted. I think those are the best estimates at the moment. But I think we are really uncertain about the extent of the we are certain that there is a problem that that will affect a significant number of people. We are uncertain about what that number might be, and we're uncertain about the duration of symptoms, and we're uncertain about the other things that I talked about earlier on. Services are being established, specialist services for long COVID are being established, and indeed we're going to try and make sure that we can link data on who is being treated in these new long COVID services with the rest of the data to understand better the need and the characteristics of those patients. And I think similar uncertainties, there have been a couple of questions in the chat about symptoms, and there are similar uncertainties. Early in the pandemic, Open Safely, Q Research and others, again, analysing data on tens of millions of patients, established risk factors for COVID. Most importantly, age, as everybody knows, but also overweight and obesity, diabetes, and so on and so on. Those were, of course, very important in designing shielding strategies and in designing vaccination strategies. So risk factors for long COVID are going to be strongly related to, and in the risk factors for getting COVID in the first place. if diabetes or indeed diabetes risks, or to use another example in a question, asthma or asthma risk, influence your probability of getting COVID and then getting severe COVID, they're likely to influence your possibility of, they're likely to be outcomes or related to outcomes of long COVID as well. And that's all going to require a lot of detailed unpicking, it seems to me.
Thank you. I mean, Claire, do you have anything to add on that from the work that you've been doing?
Well, I will add something from the app, because one of the things about the app is that we've got really good time series for different individuals. And I think one of the problems in understanding the numbers is actually because of that gamma-shaped distribution, of the fact that some people are having symptoms for 4 weeks, some 5, some 6, some 7, etc. But overall, there's a diminishing number. Looking at some of these time series this morning, actually, in one of our studies, it's very interesting because you can really see when you look at individual time series how different this disease is for some people. And there are clearly some people who have a large number of these symptoms that have gone on for really the whole of the duration since they had COVID, over a year ago. And then there are other people who have very, a sharp demarcation of symptoms for 28 days, 30 days, 50 days. And really, I think there's a lot more work to be done about really identifying, what are the differences here between the different presentations? What is the difference between the people that have had really very long symptoms and ones that do get better? And I think we've got to do more research around what are the things that differentiate those groups.
Thank you, Claire. One more question here we've got about the MRI imaging, and this is actually a specific one for you, Chris, because it's about the MRI brains in post-COVID. It's been widely reported that COVID infection was associated with a 10 years increasing in your brain aging. Is that something that is actually held up with the data that you've got from the MRI and brains, and do we think that that's going to be going forward?
So it's too early to say really exactly what the long-term effects are in the brain. We have a brain working group. As I said on one of my earlier slides, we also link up with COVID CNS, which includes imaging. And the community studies also include MRI imaging using the same strategy as in FOS-COVID. So collectively, these data actually will be really informative, together with small studies on functional MR and also looking at biomarkers. So as part of the brain group, we've actually identified neural damage biomarkers, which are currently being tested within samples in FOS-COVID. So that's not really given a clear answer to the question, other than actually saying that there's a lot of data that's actually going to come out in the very near future, which will really start to address that question.
Thank you. And so I've got one last question that I'm going to take, who's actually commenting on the fact that a few of the patients he's seen with this have benefited from breathing exercises and yoga. Sally, is this something that is going to be going forward integrated? Do you think that that is likely to have a foundation in the science?
Well, I think a number of people are presenting with dysfunctional breathing. I think that's been well documented now in a number of clinics. So I think that physiotherapists in particular have skills in managing that population, and it may well be that the techniques of yoga mirror some of the advice that you get for dysfunctional breathing. So I think that, like everything else at the moment, there's probably more research to be done, but on the basis it's not a harmful intervention, I suspect it's worth a go.
Thank you. So with that, we are coming to the end of the time for this thing. So I'm just going to ask our experts for one quick sentence for what is the learning, what is the one thing we want to take away from this that the audience can put into practice, whether they be clinicians, researchers, or working across the spectrum. Amy, you first.
I guess this is a plea to my colleagues out there to examine your patients. Long COVID cannot be solely managed over the phone. Too many patients I've seen recently diagnosed with anxiety and given SSRIs over the phone rather than being diagnosed with dysautonomia and other treatable conditions. So please examine them face to face, lay your hand on them, it will help.
Jonathan.
What we don't know about long COVID exceeds what we do know. And so we've got a large number of patients with urgent clinical needs. To to manage those patients will require unprecedented and rapid collaborations between health service providers and researchers. And those collaborations are in place, and there is extraordinary goodwill and work going on to try to make sure that patients get the services they need as rapidly as possible.
I think my point that I'd like to say to everybody is, don't be afraid of health records linkage and the ability that we now have together to really study new emerging diseases like long COVID. It's really important for all GPs and doctors generally to understand that there are very strong safeguards for researchers that are using this data, and the amount that we can learn is really huge from these data sets, which then can be rapidly disseminated into differences. So I would plead for everybody in the audience, as it were, to make sure that they code these cases in the GP records, and that they support the safe and careful use for health research for public benefit of these data.
Chris.
So this is really going to be focused, I think, on patient-centered care. So it's going to be trying to understand what are the problems the patients are presenting with, and many of those will be able to be managed in the community. But there are also long COVID clinic networks and support in secondary care. And I think as the data starts to identify underlying mechanisms in groups, then we can also then start to move on to personalised interventions. And that's where I think we're actually really going to start to unpick and really treat the patients that are most troubled with long COVID.
And Sally?
Well, just like everyone else, I think there's a real pressing need for rehab, and that needs to be integrated into the pathways. And I would hope that with the funding release that we begin to acknowledge that. But just as Chris said, I think we need to be able to understand why and how it's working, and actually then match the right people with the right intensity or mode of intervention.
Thank you very much. And so there we have it. This Board of Science event is now drawing to a close, and what we've heard is that this is a brand new condition. But as with many other diseases, the UK is very much at the forefront of the research for developing the causes, the treatments, and actually pushing ahead and making sure we do have a way of tackling long COVID for these million people within the UK, and then potentially millions of people around the world who can benefit from what we've put together. I want to thank Professor Jonathan Stern, Dr. Amy Small, Dr. Claire Steeves, Professor Chris Breitling, and Professor Sally Singh for giving us their expertise. And on that note, I'm going to hand back to Professor Parveen.
Oh, thank you very much, David, and thank you, panel. I think there's been a wonderful round of questions that have brought lots of practical problems, which I think are important in a subject we don't know too much about. So thank you for all your summary. Just to make one or two points, I think what this webinar has pointed out is the massive effect that long COVID is going to have on the population's health. We've also been warned because there's such a wide set of symptoms, complex symptoms that patients present with, that we mustn't miss some diseases that obviously we would have thought of in the past. And I think Claire pointed that out. I also would agree with what everybody is saying, that these patients do need support. We must listen to them. And thank you, Amy, for saying that we need to examine them. Because we may again be missing things. Rehabilitation, thank you again, huge demands, huge needs. Just the number of people that were on your website has actually shown that as well. So I think overall, I think what has told us that we are going to require a huge budget. The NHS is going to be swamped with it, and I think we really do want to make sure there's sufficient funding for us to actually cope with this onslaught. It's almost a pandemic after a pandemic, which is leaving us. But also research is just so important, and all of you have shown us how how wonderful it is. And thank you so much for your enthusiasm and also explaining to us what you're doing. And I suspect, I must say, listening to Jonathan, I think he won't be sleeping at night. In fact, none of you should be sleeping at night. There's too much work to do. So speakers, thank you very much indeed. Attendees, again, thank you so much for sending in your questions, for your attendance. But can I please urge you to fill in your evaluation forms, because they're just so important for us to actually see what's, how we did and whether this was helpful or can we do it better. Lastly, I'd like to thank the team who brought it together, particularly my co-host, but also the people behind the IT, the Board of Science team, which have put together a lot of time, put a lot of effort and time into this. So thank you all very much indeed for attending. Just to say that this will be on the website of the Board of Science in time. So if you want to look at it again, you can certainly do so. So thank you all. Thank you, David, for being my co-host. Goodbye to you all and have a superb rest of the day in, I hope, sunshine. Thank you. Bye-bye.